everyone. My name is Haley Buckner, and I'm the Director of Professional Relations for Elevate Oral Care. Thank you so much for joining us this evening. Before we get started, I'd like to take a moment to cover a few quick housekeeping items. For those of you who remain online for at least 75 minutes, your CE certificate will be emailed to you within hours of this presentation. Please be sure to check your spam folder just in case it ends up in there. You are all currently muted, so there's no need to worry about background noise during the session. We will have time for Q&A at the end of the presentation, and you can submit your questions through the webinar dashboard as we'll be tracking them throughout the talk. We posted an extensive series of free live CE webinars on a variety of prevention topics. These webinars are recorded and available for free self-instruction CE at the website you see on the screen, elevateoralcare.com/elevatingcare. Please be sure to bookmark that page and check back often for new free CE opportunities. We also invite you to suggest a topic. So if there's something specific that you'd like for us to cover in a future webinar, please feel free to email your suggestions to info@elevateoralcare.com or complete the webinar survey that will be sent to you after this evening's session. Tonight, we are honored to be joined by Shelley Brown and Sue Kump. Shelley Brown is a dental educator, speaker, content creator, and mobile clinician dedicated to advancing accessible and innovative dentistry. As co-owner of Hygiene Educators, she empowers dental educators through professional development. Since 2009, she has taught at the Utah College of Dental Hygiene and founded Homebound Smiles, a mobile dental practice serving underserved patients. You can follow her work as Shelley the Hygienist on YouTube, TikTok, and Instagram, as well as her website, www.shelley.dental. Thanks so much for being here tonight, Shelley. Next, I'm going to introduce you to Sue Kump. Sue is a creative, dynamic dental professional with over 40 years of experience spanning clinical, practice management, distribution, and manufacturing. She has held many leadership and board positions within the dental industry, utilizing her professional and educational experience. She is a licensed and certified dental assistant and holds a BS in marketing management and an MBA. Thank you so much for being here, Sue. And with that, I'm going to go ahead and turn it over to you.
Thank you so much, Haley. Today, we're going to talk about desiccation technology in dentistry, the science and clinical application of sulfonated phenolics. Before we get started, I just want to share with you our disclaimers. So I'll give you a second to read those. All right, so let's talk about desiccation technology. Desiccation technology was invented by Dr. Michael Basara. And let me tell you a little bit about Dr. Basara. He received his undergraduate degree from the University of Minnesota School of Biological Sciences and his medical degree from the University of Minnesota as well. He is board certified in clinical and chemical pathology. Dr. Basara was Chief of Laboratory Services for the Upper Midwest region of the VA hospitals. And this is where his vision to develop a product to treat chronic wounds without the use of an antibiotic was born. Dr. Basara researched with the Center for Biofilm Engineering, Montana State University, alongside the esteemed Dr. Bill Costerton and other clinicians. And desiccation shock technology was a result of his vision and was patented. Desiccation shock technology has many uses. It's focused on diseased and infectious tissue. Diseased and infectious tissues in oral health care, acute and chronic wounds, burns, surgical site infections, dermatologic infections, precancerous skin lesions, solid tumor mitigation, and veterinary care. Its patented mechanism of action is a smart formula, so it has a selective action. It has positive visual results in seconds. It desiccates all bacteria, yeast, fungi, and viruses, neutralizes infectious conditions for faster healing of wounds. Remember, periodontal disease is considered a chronic wound. So let's talk about this method of action and how desiccation is used in dentistry. So desiccation is just that simple physical process that removes water from a combination of infectious microbial material, dead cellular debris, and other macromolecules found around the tooth and prosthetic surfaces in the oral cavity. So if we look at these slides here of plaque biofilm under a scanning electron microscope, upper left is your lowest magnification, upper right is your highest magnification. And you can see in the higher magnified slides, you can see the strands or the organic component of the biofilm. Your little grape-like clusters are the gram-positive bacteria. The little rods and sausage shapes are the gram-negative bacteria. And these bacteria are living organisms and they need water to survive. And the desiccation actually dehydrates the environment, so these pathogens that are causing the periodontal disease cannot survive. So Dr. Basara's patented formulation for desiccation contains sulfonated phenolics. And these sulfonated phenolics produce an electrostatic charge that attract both the free and molecularly bound water that's sitting in that unprotected gel matrix of the biofilm, thereby desiccating and denaturing the biofilm. So it removes all the bacteria, the senescent cells, the funguses, the viruses. The entire microbial environment is dead. And this happens within 10 to 30 seconds of desiccation. So if we look at these lower images, they're the same area plaque biofilm, but only after 30 seconds of desiccation, you can see how that biofilm is collapsed so it looks like peeling paint. This is the tooth root surface, okay? And then in the higher magnified slides, you can see how that biofilm has collapsed. So once again, this desiccation happens quickly. It works in the first 10 to 30 seconds of contact. So there's rapid desiccation, and then the sheer force of the mechanical rinsing and the density of the product allow all the dead microorganisms and tissue debris to be loosened and rinsed away. So it's this coagulum of devitalized non-pathogenic material that's simply just loosened and rinsed away after that 30 seconds. So with all those pathogens gone, the environment of the periodontal pocket immediately converts from one that allowed disease progression to one that slows the disease and supports the healing. By removing the pathogens and reducing the inflammation, the body can begin its healing process immediately. You're not waiting days, weeks, or months for a product to take effect. Okay, those fibroblast cells can start firing back up to promote that healing. Now, I did mention that this desiccation destroys all the pathogens, so it also takes with it that healthy flora or that commensal bacteria, but that begins to regenerate within 24 hours. And after 48 hours, it's laid down a nice healthy layer of that good, that commensal bacteria. So that's how sulfonated phenolics work, by rapidly dehydrating the environment. That's why there's no need for the use of an antibiotic, because the sulfonated phenolic has altered the environment. It's dried, dehydrated the environment, so the pathogens can no longer survive. So now you're probably wondering, okay, well, what the heck is in these sulfonated phenolics that causes this rapid desiccation or dehydration? So the formula is a combination of sulfonated phenolics and sulfuric acid. And if you're like most people, when you hear sulfuric acid, you're like, whoa, wait, this is going to burn my patient's tissues. But the sulfuric acid in the patented formulation is highly concentrated. Therefore, it's not expressed as being acidic. If you think back to your physical chemistry classes, highly concentrated acids do not dissociate their protons, which is what we typically think of when it comes to acids, and it's what creates that acidic action. The sulfuric acid in the patented formulation is highly concentrated and is less acidic than orange juice or yogurt. So it's 3 acidic compounds blended at a very high concentration so that they cannot acidify the environment. They pull water to themselves. They do not allow water and protons to go away from them. Now let's look at how tissues respond to desiccation with the sulfonated phenolics. So when we look at healthy tissues, they have closed cellular walls, but healthy tissues are semi-permeable. So moisture is going to be drawn out of that tissue, leaving it blanched. And this is perfectly normal to see when you're using sulfonated phenolics. If we look at this first image here, you can see this blanching of the tissue. This is not a chemical burn. It's a result of dehydration. The water, that chemical action of the sulfonated phenolics has extracted the water out of that healthy tissue. And this blanching is temporary. This will last for several hours, excuse me, typically 3 to 4 hours. And then that blanching will dissipate. The patient will begin to rehydrate and that tissue plump back up. So that blanching is temporary. It lasts for a couple of hours. Now, I also mentioned earlier that the sulfonated phenolics work quickly. They work in 10 to 30 seconds. So do not leave the sulfonated phenolic on longer than 60 seconds. Do not leave it on longer than a minute, because it's only going to continue to pull more moisture out of those healthy tissues, and then your patients may experience some tissue sloughing. Now, also remember the oral mucosa turns over every 3 to 5 days. So you may leave the sulfonated phenolic on for 20 or 30 seconds and notice a little tissue sloughing. It was more than likely that tissue that was in the process of turning over, and you just helped it along by dehydrating it. But for the most part, your patients are only going to experience this temporary blanching of whatever tissue the sulfonated phenolic has come in contact with. Okay, it's good at seeking out moisture, which we just talked about. It goes after water. Those sulfonated phenolics are attracted to the water. So this is where the selective action comes into play, because when we talk about damaged tissues, they have weak cellular walls. So the sulfonated phenolic can quickly go after the water that's in those damaged cells, and then between those cells where all that bacteria-laden biofilm is incubating all those pathogenic microbes. And once that biofilm has been dehydrated and denatured, that tissue then can resume its normal function. The fibroblast cells can start firing back up to promote the healing. Now, some other cool benefits we learned about using sulfonated phenolics are that it actually will temporarily relieve edema, and it shrinks and tightens the tissue, and it provides some temporary hemostasis. And these effects last for about 20 to 30 minutes. So we suggest when you're using a sulfonated phenolic that you work in a small area, up to 6 teeth, so you can really control the placement of the product, but more importantly, reap the rewards of this shrunk and tightened tissue. You can see how the sulfonated phenolic pulls moisture out, and it pulls the tissue away from the tooth and the root surface, so you can see what you're doing. And then as it's pulling moisture out of the tissue, it's also sealing off the capillaries, so it provides that temporary hemostasis. So that sulfonated phenolic is going to shrink and tighten the tissue and provide you that temporary hemostasis for about 20, maybe 30 minutes. Now, sulfonated phenolics are also considered to be self-limiting through coagulation. And what I mean by that is as the tissue surface macromolecules are being denatured, an increasingly thick layer of tissue coagulum is being formed underneath it. And at some point, that coagulum becomes so thick that the strength of the water extracting force of the sulfonated phenolic is no longer sufficient to pull any more moisture through it due to saturation. So whether this happens in 1 minute, 2 minutes, 3 minutes, doesn't matter in the dental application, because we're only leaving the sulfonated phenolic on for less than a minute. It's typically on for 30 seconds. So let's talk about some of the benefits of using a sulfonated phenolic. First of all, it's an antibiotic-free cleanser. We just talked about the ingredients. It's a non-biologic, so you do not have to worry about bacterial resistance. Say you have a patient that has a 7mm pocket. You apply a sulfonated phenolic and you get them back for their tissue check. That pocket's now measuring at a 5. You can reapply the sulfonated phenolic and not have to worry about bacterial resistance. The sulfonated phenolics work in less than 30 seconds to eradicate those pathogens and remove that smear layer. It will debride the necrotic tissues to promote that healing. Those fibroblast cells, once again, can start firing back up right away. You're not waiting days, weeks, or months for a product to take effect. And there are no post-treatment restrictions for the patients to remember. So the success of using a sulfonated phenolic is not on patient compliance. The hemostatic properties are great for you as clinicians. It stops the bleeding. You can see what you're doing, but your patients are more comfortable as a result. They're not tasting hemorrhage throughout the procedure. You're not stopping as often to rinse and get them comfortable. Pre and post scaling benefits. This is where it's very unique when you use a sulfonated phenolic, because using a sulfonated phenolic on the calculus or tartar pre-scaling actually breaks down the organic components in the calculus. So the calculus or tartar becomes softer. Many clinicians tell us it becomes the clay-like, the consistency of clay. Some report the calculus becomes more brittle, but for the most part, we hear it becomes softer. So it's easier for them to remove, and the patients are more comfortable as a result. And then using the sulfonated post-scaling is where the patients will receive the biggest benefit, because after all that calculus has been removed, the sulfonated phenolic can flow down into the base of the pocket, into any root irregularities, furcations, overhangs, and do a great job of dehydrating and denaturing that biofilm to promote that healing. So sulfonated phenolics can be used pre-scaling and post-scaling, or both, and I'll talk about that more here in just a bit. But when you use the sulfonated phenolic pre-scaling, it's going to save you a little bit of time, but not a lot of time, a little bit of time with your scaling. But we hear from hygienists that they have less hand wrist fatigue at the end of the day when they use the sulfonated phenolic pre-scaling. And it works well with other adjunctive products and procedures. So if your practice already has a revenue stream using a diode laser, you can use a sulfonated phenolic to soften the calculus pre-scaling. If you use guided biofilm therapy or air polishers, you can use those post-treatment, because that nozzle typically doesn't reach past 5 millimeters. And if your patient has a mouth rinse protocol or tray method, those products can be used as maintenance products by the patient for their at-home use. So it does work well with other adjunctive procedures and products. So I asked some hygienists, when do they know that they're going to use a sulfonated phenolic? And they say for patients that bleed upon probing and have plaque present, patients that have periodontal pockets, patients with calculus or tartar, and patients that have stain. Now, the sulfonated phenolic is not going to melt the stain away, but it's going to make it much easier for you to remove. This next slide, I have some clinical indications for when to use the sulfonated phenolic. So if patients present healthy and that have advanced calculus, using the gel formulation, pre-scaling, supra, and you can go subgingivally too, to soften the calculus and remove stain. The sulfonated phenolics have two formulations, a liquid and a gel, and the gel is mostly preferred for periodontal treatment. So the gel is what we recommend. For patients that have active gingivitis, using the gel Pre-scaling supra and subgingivally, once again, to soften the calculus, help remove the stain, and provide that temporary hemostasis. And then you may want to consider using it post-scaling in any areas where there's dysbiosis or that angry tissue to help reverse that gingivitis. And then for patients that have active periodontitis or they're in for their perio maintenance appointment, we recommend using the sulfonated phenolic both pre and post scaling for optimal results. Pre-scaling for the benefits we just talked about, softening the calculus, removing the stain, providing that hemostasis and for patient comfort. And then post-scaling, applying the sulfonated phenolic only subgingivally this time to treat any areas of pocketing or dysbiosis to eradicate those pathogens and debride that necrotic tissue. Now, there are some additional uses in dentistry for sulfonated phenolics. It can also be used as a caries and crown prep cleanser. So after the caries preparation has been completed, before a base or an etchant is used, you can use the sulfonated phenolic to cleanse that preparation to remove that biofilm and smear layer. Then go ahead, apply a base, and then do an etchant. Remember, sulfonated phenolics are not acidic, so they're not replacing the acid etch. And then in the event of interproximal bleeding for that preparation or a crown prep and the retraction cord is pulled out and there's still a little bit of hemorrhage, the sulfonated phenolic can be applied around the margin of that crown preparation. It will stop the bleeding, it'll shrink and tighten that tissue, pull it away, dry out that area for a nice, crisp, clean image, digital impression. And then I mentioned that the sulfonated phenolic also has a liquid formulation, and that formulation was really developed for the use as a root canal cleanser because of the lower viscosity. So the liquid formulation must be used for the root canal cleansing aspect. It'll flow nicely down to the apex of the root, really do a good job of irrigating those canals, stopping any hemorrhage down at the apex, remove all that dentinal debris, that smear layer, and get those canals nice and clean. And the sulfonated phenolic can be rinsed away with either sterile water or sodium hypochlorite. So those are the other two applications for using a sulfonated phenolic in dentistry. Now let's jump back over to using the sulfonated phenolic for periodontal treatment, because I want to walk through the application steps. Once again, this would be using the gel formulation because the viscosity of the gel is like a runny honey, and then when it's warm to body temperature, it becomes less viscous or runnier. So it's very nice and easy to control the gel formulation. So the first thing we want to do when using a sulfonated phenolic is isolate the treatment area. Remember, whatever tissue comes in contact with that sulfonated phenolic is going to be blanched. So from a patient comfort and aesthetic standpoint, you want to isolate the treatment area using a cotton roll, a gauze, dry angle, whatever your isolation techniques are, and then remove any excess moisture. Use a gauze or your air syringe and just dry the area the best you can. We understand there's going to be saliva and hemorrhage, but just remove any excess of moisture, because remember, the sulfonated phenolic attracts water, and once it pulls in enough water, it can start to lose its efficacy. So we want it to be in its most effective state. So we're going to isolate and dry the treatment area. Remember, we're working in small areas. We're working in sextants. And then apply the sulfonated phenolic using, this is the gel formulation, so you can see how it'll stick to the calculus and the stain. So apply a generous amount supragingivally, cover all the calculus or tartar and the stain. You can go sub-G too. Then wait 30 to 45 seconds. Some hygienists tell us for very tenacious calculus or that burnished calculus, they'll wait up to 45 seconds, even a minute, but do not leave it on longer than 1 minute. And then this next step is very important because you want your patients to have a comfortable experience. After your time is up, you want to evacuate the excess product away. Use high volume evacuation if it's available to you. Evacuate the product and then rinse and evacuate. This is really going to reduce the chance of them tasting the product. The sulfonated phenolic has a sour, some patients say bitter taste. So for patient comfort, be sure to do that. If you forget and squirt water in and have them swish, not only is the patient going to say, oh my gosh, that tasted horrible, but now you've spread the product around and you'll see blanching in other areas, other tissues that you were not intending on being in contact with the sulfonated phenolic. So be sure to evacuate and then rinse and evacuate. And then after the product has been removed, you can see that temporary blanching. Once again, this is normal. This will last for several hours. And then as the patient rehydrates, the color will restore. Then go ahead and do your scaling, either hand scaling or your ultrasonic. Go ahead, do your scaling. And then if you are going to use the sulfonated phenolic post-scaling to treat any areas of pocketing or dysbiosis, you'll follow the same application steps. Isolate and dry the treatment area. This time only apply subgingivally. Wait 10 to 30 seconds, evacuate, and then rinse and evacuate. And on your final rinse, post-sulfonated phenolic treatment, you are going to see a lot of debris coming out of those pockets. The sulfonated phenolic does a good job of loosening and lifting all that debris. So you'll see a lot of brown and black flecks coming out because it's really cleaning those pockets out well. Now, when the sulfonated phenolic is being applied, some patients say they feel a tingling or a cold sensation. This is perfectly normal, and these sensations will last until the product is removed. If you are going to use a topical anesthetic, we just ask that you remove all the topical residue before applying your sulfonated phenolic because you do not want to risk a chemical interaction. So just do a good thorough rinse if using a topical anesthetic, but you do not need to use any form of anesthetic when using a sulfonated phenolic if it's not warranted. So some key things to remember, you can use the sulfonated phenolic on up to 6 teeth at a time so you can control the placement of that gel, or if you choose to use the liquid, but you can control the placement and reap the benefits of that shrunk and tightened tissue and that temporary hemostasis. The sulfonated phenolic must be washed off within 60 seconds. You may see some temporary blanching of the tissue that it's come in contact with, depending upon how much the sulfonated phenolic got on that tissue. You may see a little blanching, you may see quite a bit of blanching. And then once again, the patients may experience a cold or tingling sensation when the product is being applied. And then after it's been removed, they may say it tastes sour or bitter. Slightly, but you're removing as much of the product as you can. And then I just want to show you some slides of some application errors that can be avoided by following the application steps. This image here, the sulfonated phenolic was left on up to 3 minutes. Okay, it's only going to draw more moisture out of that healthy tissue. Do not leave it on longer than 30 seconds. And then these side images here just show what can happen to the tissue if isolation is not used. So from patient comfort and aesthetic standpoint, be sure to isolate your treatment areas. And then once again, work in small areas so you can control the placement of the product. From a post-procedure instruction standpoint, there's no need for your patients to avoid eating or drinking anything post-application. They can return to normal hygiene. They can floss, brush the area, use a water flosser. If you are going to recommend that they use another antimicrobial product, you just want to ask them to wait 48 hours after the sulfonated phenolic has been used. And the reason being, you want time for that commensal, that good bacteria, to regenerate. Once again, the areas of healthy tissue may appear blanched, but they're going to return to their normal color for sure within 24 hours. And then if you have patients that you're concerned may have some sensitivity post-scaling, and then of course, if you're using a sulfonated phenolic, you might think, oh, the area might be more sensitive. We have some possible solutions that we've heard from clinicians. Some offices tell us they use this as an opportunity to apply a fluoride varnish immediately after. Some practices use ozone therapy. Others will use a povidone iodine product or the rinse. Some will recommend the patient use a remineralization toothpaste at home or use a fluoride varnish. And then from a contraindication standpoint, if your patients have allergies to sulfur or red dye 40, you'd want to avoid using the sulfonated phenolic. There are no known contraindications for patients that have allergies to sulfa, the drug. They're two different things. If the patient had an unknown allergy or sensitivity to sulfur or red dye 40, the area would more than likely appear red and possibly blister. But remember, this is a topical cleanser, so a good thorough rinse is typically all that's needed. Now I'm going to turn the presentation over to Shelley Brown. She'll show you the effects of using sulfonated phenolics and share some of her clinical cases with you.
Sue, thank you so much for that introduction there and for all of the background information on what we are learning about tonight through this desiccation technology. And as I begin this next section of this presentation, I want to ask you this question because I think it's really important. So I read this in a textbook not too long ago, learning about instrumentation, and it says that subgingival periodontal instrumentation must cover every square millimeter of the root surface. Now, question for you, is that true? Obviously, it was in a textbook, so you know that it is. But is it possible? Now, with my ultrasonic unit, especially as a student, I remember thinking, if I just do one big sweep across this root surface, I'm going to get all the calculus, right? And we know that it's very difficult to remove. And even though it's a tiny little tooth, every square millimeter has to be disrupted. And with our instruments that we currently have, our hand instruments and our ultrasonic scalers, we inadvertently do miss areas. And we're working subgingival where we sometimes often cannot see. And we often cannot see the biofilm, which is the true, problem or main cause of periodontal diseases, and it is very hard to see. And so we need some supportive or adjunct medicaments to help us better instrument and be able to access every square millimeter of that root surface. Now, I learned about this product probably 4 or 5 years ago now from Sue at the National Mobile and Teledentistry Conference. And I attended that conference because I run a mobile dental hygiene program here in Utah. So I work autonomously, seeing patients in public health settings. Mainly, I'm in care facilities. And when I first learned about it, I thought this is something I need to bring into my practice for a few reasons. One, I don't want to carry in big, bulky equipment myself because I'm, portable. So I'm walking everything into their room, essentially. And so it makes it really manageable that way. I wanted something that I could fit into every area easily, not just localized areas. So that was one awesome thing I remember learning from her about. And then 2, my patients are at high risk for aspiration pneumonia, and a lot of them are laying down in their bed and cannot sit up. So if you can imagine me using an ultrasonic on an elderly patient with lots of water, that's not going to go well. And I did not want my patients having any issues with aspiration of any of that water and leading to aspiration pneumonia. And so this became a really vital product tool for me in those settings because I could soften that calculus and really help destroy this biofilm a lot better and interrupt the biofilm a lot better in these settings where patients literally have no health care, no oral health care at home. They're getting minimal toothbrushing, they can't do it themselves. And so it really became a product that I have loved incorporating into my practice over the last several years. And so we can add it to our amazing options that we already do have. You can see here on the screen, trays with hydrogen peroxide, your lasers, antibiotics if you're still wanting to use those, our air powder polishers, and so forth. So this is something else that we now have this tool in the toolbox. And my job here is to go over with you the many studies and research and evidence that we have, because every time I have talked to someone about it, they're like, well, give me the evidence. What has it has said about it? And it's been studied for many, many years. As Sue had mentioned, there's been a lot of study that has gone into these sulfonated phenolics and desiccation technology over many, many years. So first, before we dive into some of the studies, I'm going to back up for just a second and go over Sokransky's research that came out in 1998, because it's going to help us better understand some of the science and evidence. So you can see here on the screen what they talked about. They divided all of the bacteria into clusters, and I love that they color coordinated this for us. Who else out there loves color coordination, right? But you can see here that they kind of categorized our early initiators, early colonizers, our commensal bacteria into this bottom row where we've got blue, purple, green, and yellow. And then you can see that orange area where they're more anaerobic, gram-negative, starting to get an imbalance. And then our purple, or our purple complex bacteria, I meant to say red, our red complex bacteria, excuse me, are our major etiologic agents of periodontal diseases. So sometimes you'll hear this red complex bacteria. So as I show you the study here in a little bit, it'll help us understand what we're looking at. So with that, our blues, just a reminder, they're our early colonizers, they're in health. Our purples, they're they're not pathogenic. Same thing with our yellows, but our greens, this is where we start to get maybe some more gingival inflammation, which leads to the buildup then of our orange complex bacteria. Kind of sets the stage for our more severe diseases. And you can see in each one of these categories, I've listed out just some of the many. There's over 800 bacteria in the mouth at times, right? You can see some of them that are more virulent in these different complexes of bacteria. And then you can see there at the very top, our red complex bacteria, our P. gingivalis, and that one is definitely lining that epithelial periodontal pocket, which is usually adjacent to that periodontal pocket, and more virulent, and is really driving that inflammation on our patients. So then let's look at this particular study that they looked at for the sulfonated phenolics and desiccation technology. So what they did here, you can see they took a baseline of all these different types of bacteria, 15 days what they looked like after placement of the SRP and Hybenex, 60 days, 180 days, 365 days. Now you can see at the bottom in the key, the blue line is going to be if we used a sulfonated phenolic with our periodontal therapy, SRP is periodontal therapy down there, what happens? Okay, and our red line is just scaling alone, and we can see what happens. So with this, they looked at all of these different complexes, the blues and the purples and the yellows and the greens and the oranges. And most of those return back to normal. So as Sue mentioned, those commensal bacteria, they take in that zone where they were, where the medicament was placed, are destroyed, and they bounce back pretty quickly. But where we see the most awesome and exciting results is our red complex bacteria. Now let me blow this up just a little bit bigger for you so we can dive into this particular section. So at baseline, we can see that our red and our blue line are pretty much the same. When we initially see a patient, we know that they have a periodontal disease. They are teeming with, P. gingivalis especially. That's the one that's found most commonly, that keystone bacteria in our periodontal diseases. At day 15, we see that that blue line is at 0. At day 30, we see that the blue line is at 0. Now, 30 days with just the scaling and root planing alone, we see that bacteria return about halfway. And so then at 60 days, we see the blue line still at 0. But we do see that that bacteria returns about 3/4 the way, and it stays about 3/4 the way with scaling alone, even up to a year. Now that's pretty good if you're scaling alone, but usually you can see at that 60 days, that's when we're wanting and why we're wanting to see patients back for their 3-month recare, because we know that that bacteria returns and we need to keep it low. So we do our instrumentation and our periodontal maintenance visits, at that 3-month mark. But what I loved the most is even after 365 days, you can see this blue line barely has a blip of that P. gingivalis. Now, when I first saw this, I was so excited because I'm seeing my patients every 3 months still. I'm not telling you by any means to change your monthly recare, but for my patients, many of my patients have Alzheimer's. We know that that P. gingivalis is found in the brains often of our Alzheimer's patients. And where does that come from? We know it's coming from the oral cavity, right? And so to be able to keep these most virulent bacteria that might be causing systemic problems low for longer for patients, I think is really, really exciting. And that's why I obviously implemented it into my practice. Here's another study that was done. They looked at a confocal depth microscope, and they looked at bacteria before, and they looked within these different layers. So as I've mentioned to you, the Sokransky's colorized model, the early colonizers down here below, the blues and the purples and the greens and the yellows, you can see here on the screen, that's our base of our biofilm. And then our middle is our orange, and then our surface is our reds. Okay, so if we place this sulfonated phenolic on a very grown biofilm, they're 3D large structures, will it get from the top to the base where we need it and dehydrate that biofilm and essentially suck out that water and desiccate the biofilm? Does it do it in all the layers to the depth? And you can see here on the screen, the red means it's dead. So they took another confocal depth microscope look, and they found that there was no more green in that area. So you can see the base to the middle to the surface, all was completely desiccated, helping us to eradicate these biofilms. Another one that I want to look at with you, another study, is this one where it looks at all these different types of bacteria. So you can see here on the screen, this is before. So before we even start periodontal therapy, we see that there's AA is our Aggregatibacter actinomycetum comitans. We see our Porphyromonas gingivalis here, and then we see several others at these high levels, right? So Sue had mentioned a little bit about placement, right? So she mentioned we place it first, and then we can instrument, and then we want to place it again. So one reason why is because of this study that was presented. So with our first application, before we even start instrumenting, you can see that there are, no levels of our AA, our PG, our TF, a little bit left of our eubacterium, our micros. You can see here just a little bit is left. So then we instrument, and then you can see at the second evaluation after we place it, right before we're done with treatment, how it's completely eradicated that bacteria that is in the area. Also very exciting to me as a clinician working with patients who are at higher risk for Porphyromonas gingivalis, and super exciting. So with that, what they found, okay, so this particular study found the combination adjunctive of a sulfonated phenolic, that's the SP, periodebridement, PD, and then a sulfonated phenolic treatment indicated a complete absence of detectable bacterial DNA. So that's awesome. Okay, we got into all of those nooks and crannies, all of those little square millimeters that maybe we couldn't reach with our instruments. It also goes on to mention in this study as well as reducing the 4 inflammatory mediators from samples taken from the gingival sulci. So let's next go into how it works on inflammation. So we've been talking all about bacteria and how it desiccates the biofilm, but it also has a really amazing impact on inflammation, which, as we know, bacteria obviously stimulate our immune system of our patients, And then with that stimulation, it essentially, that's how we fight off the bacteria, right? So inflammation in our immune system is a big piece of the puzzle here when we're trying to fight periodontal diseases. Sometimes even if we have the bacteria in our mouth, it doesn't always mean that our patients have a periodontal disease. You can actually have the bacteria, but maybe not an active infection because your immune system is working well. So this does have an effect on the immune system. So there are, as it mentioned, there's several inflammatory mediators, but this particular study focused on the interleukin-1, interleukin-6, our tissue necrosis factor alpha, and our MMP8. In particular, there's 12 different types of MMPs, but the one that's mostly for periodontal diseases is our MMP8. So in our immune system, you can think of it this way. What happens is these come into the area to help fight the infection, right? So if you think of these as like, there's a fire happening, right? There's an invasion of bacteria. We send in these inflammatory mediators. So there's fire everywhere, and these are kind of like our water hoses, right? So our water is flying in, it's trying to destroy and all of these bacterial pathogens. But in the midst of all that, putting the water on the house that's on fire, it creates damage beyond what we might want to see. What I mean by that is it creates collateral damage and destroys the tissues that hold our teeth in, all of the collagen and the bone inadvertently as it's trying to make pathways for the bacteria and our immune system to come into the area and fight the bacteria. So what we see here is these inflammatory mediators, they do not just stay local, right? They're not just staying local in only the areas of the gingiva. They spill into circulation, and that is what is going to continue to fuel chronic, low-grade, systemic inflammation. So the work that we do with periodontal therapy is so important for overall health as well. Also, these elevated cytokines contribute to endothelial dysfunction. So they lead to insulin resistance and immune dysregulation over the whole body. And so having the sulfonated phenolics be able to work on this aspect as well is very beneficial to our patients' overall health. So I have a list here of several of these inflammatory mediators. These are the key ones in periodontal diseases. The interleukin B1, you can see there that what its job is to do is remove infected bone. Now, most of the time when we see destruction of the periodontium, our body cannot keep up with that removal of infected bone, and so we see bone loss on our radiographs, right? But we have to remove that infected tissue. We're hoping that it is replaced with some healthy bone, but that's what starts to happen with our interleukins, and if that gets overwhelmed, then we see permanent damage. So our interleukin 6, it helps to sustain chronic inflammation. There's times where we know that this is a chronic inflammatory disease and we need our inflammatory mediators to stay there for a while and fight off this bacterial infection to prevent it from going systemic as much as possible. So it continues to stay there. It also is telling the rest of the body, essentially telling the liver to produce CRP. So it's here in the mouth, it's here in the liver, and these interleukins are transferring systemically. Our tissue necrosis factor alpha, it's going to drive strong inflammatory signaling, and that will break down the connective tissue so that more inflammatory mediators can then come in easier and faster into the area. It's kind of like little highways, and they can help fight the bacteria, help bring in more PMNs, macrophages, things like that to digest the bacteria that are in there. And then our MMP8s. These MMPs, they are normally in health as well, and they break down collagen, but usually we can rebuild collagen. But as we get overwhelmed with our system and our immune response, destroying these pathogens, then that also continues to destroy the collagen, which is what our periodontal ligament is made up of. So it degrades our host's tissues. So these inflammatory mediators are really important in obviously fighting the infection, but they do create that collateral damage. And there is a whole process actually of deregulating or de-escalating the immune response. And we do know that some patients, even though we do periodontal therapy, maybe sometimes they don't have as great of a response as we want, because sometimes there's been so much inflammation for so long, it takes a long time to get those inflammatory mediators to reduce. So this is an awesome product, as we can see through this study I'm going to show you here in a minute, to help reduce these inflammatory mediators and give our body, I would say, kind of a head start on healing. Just a reminder, the same mediators found in periodontal diseases are detected in the arteries, in the plaques in the arteries, also diabetic microvascular systems. Also, reducing our local inflammation can lower our systemic inflammatory burden and improve overall health outcomes. We had a patient at the school where I teach at recently. They could not get his HbA1c number to go below a 9. And they said, you're eating right, we're giving you the insulin, we don't know what's going on. And so when we looked in his mouth, I said, I know exactly what's going on. You have a raging infection in your mouth, and if we get rid of that, that can help with your overall health outcomes as well. And it did. It took it down to like a 6, I believe. So that was really exciting to see that what our periodontal therapies work and are very important to our patients' overall health. And I like to say it this way, that our periodontal therapy is inflammation therapy. It's not just plaque removal, it's not just tooth picking or a cosmetic tooth cleaning. It's very important work that is done. So with that, let me show you the study that talks about inflammatory mediators here. So we have our MMP8 on the upper left, our interleukin-1, our interleukin-6, and our tissue necrosis factor alpha. You can see the pre is in these blue lines, what they looked like before, and you can see that they're very high. And then we have our post peak at what these look like, and you see now at the post that these inflammatory markers are very low. So with that, they reported that the immune modulators remained below detectable limits after even just the first Hybenex irrigation. And of course, it's recommended to do it one more time at the end, which will continue to help contribute to reduction of that inflammation, obviously in the oral cavity, but systemically as well. So let's do a case here. I'm going to push play on this little video and just kind of keep it running. There's no sound on it, but you'll be able to see the placement. So this was a patient who had quite a bit of inflammation, mouth breather as well. So you can see the redness on these tissues, and also not great with biofilm control. So you'll see in this video that one thing I am missing, he was able to keep his lip up pretty well, but one thing that I'm missing there is I wish he had a little, to keep that lip up and out of the way is I don't want any tissues to touch it because it will turn white. So as Sue mentioned, make sure that you have a barrier or a cotton roll right up in there to prevent that from happening. You're going to place it around the tissues in any pockets that you also see, and then leave it for that 10 to 30 seconds, longer if you do have any calculus in the area. And then you're going to high volume evacuation, suck everything off as much as possible, and then give a rinse. And then you instrument, so you can kind of see in super fast speed on that video that I instrument ultrasonic and hand instrumentation. Quite a bit of bleeding still in some of those areas, but it definitely reduces the bleeding quite a bit, especially during that ultrasonic instrumentation. But it really helps with that because sometimes, when you're deep in a pocket and it's really hard to see, that's a little bit challenging. So it does help with that hemostasis as well. And then you want to place it at the end. And we know that because of all of these evidence pieces that say if we place it that one last time, it just really eradicates more of that biofilm. And then, as mentioned by Sue, there's no post-op recommendations on this. So the after on this patient, here's right immediately after desiccation. And you might be thinking, what is all this white on the teeth? This is the biofilm that was on his teeth that is desiccated. So it's that, like, it looks like a sludge still, but you saw it microscopically when Sue showed you those images, like a flaky little pastry or a little flaky paint. Not that it flakes off the tooth, it does kind of come off in chunks, but microscopically, that's what it would look like, is that those little flakes. So that's what those are. It's not demineralization by any means, but that's the biofilm dehydrated. And then this is 1 week after. And you can see with this patient, he still doesn't have like the greatest biofilm control. He still has quite a bit of biofilm on his teeth, but you can see that after there's quite a bit of awesome changes with redness. And so continued care with this patient, seeing them more often every 3 months. Even if a patient has gingivitis, we should see them a little bit more often. We can be doing that gingivitis scaling and seeing them more often to prevent this from progressing into periodontitis. Okay, the next one, the next awesome thing that this product does that I wanted to talk about today as well is removal of the smear layer. And Sue mentioned this just a little bit earlier. So when we do instrument, say we place Hybenex first and then we instrument, we actually leave an amorphous, granular, and irregular layer on the cementum or root surface of the tooth. And you can see here on the screen, the left side is with a brief curette scaling. There's a lot more of that smear layer left over. And on the right side is ultrasonic scaling. So because of that water and lavage, we have a little more, or a little less, I should say, smear layer on the root surface. So with that, is the smear layer even a problem? You know, if we leave this amorphous, granular, irregular smear layer on the root, does it affect healing? Does it affect anything? And I used to not even recognize what that there was a smear layer on the root surface. I had heard it in dental materials quite a bit because when a dentist drills shards of tooth structure and dentin, you know, they fly all over the tooth structure and land in dentinal tubules, and sometimes you have to remove that for bonding purposes or incorporate it into the bonds. So I'd heard of it there, but a smear layer also forms on the root surface. So is it a problem? Here's a picture of aggressive scaling right here in the middle. But the smear layer actually causes a barrier between the root surface and periodontal cells and can alter the healing process. So yeah, it does affect the healing process. If we leave it there, this is kind of an image here on the left. If we leave it there, those periodontal fibers and the new attachment, it said it will prevent the new attachment of periodontal fibers and inhibits the migration and proliferation of fibroblasts. And fibroblasts is what builds collagen, right? And that's what we need to be able to build potential new periodontal ligaments. That's what we need to be able to rebuild a junctional epithelium on the root surface. And so if the smear layer is in the way, we won't get as much healing, right? It says for the fibrous reattachment to occur, so this long junctional epithelium to occur, it must be able to contact the root surfaces. Otherwise, you know, we won't get as much healing as we want. So obviously we do want this long junctional epithelium to form, but if we could get some more periodontal ligament fibers because we have a root surface that is prepared for them to reattach back and those fibroblasts to go to work for us, depending on how much bone is lost, of course, it will help with healing of the periodontium. So how do we remove this smear layer? And obviously you guys know that we're talking about sulfonated phenolic used today in desiccation technology. So let's look at how it compares. To do this, you're going to need a strong chelator or an acid, one study said. So with that, they did a look at a few different types of products. They used a sodium hypochlorite product, not available here in America, a nanosilver product, also not available here. And they compared that with the sulfonated phenolic. And this is what they found. Sulfonated phenolics and the sodium hypochlorite provide more stable root surface due to a more efficient but not complete removal of the smear layer, but some removal of that smear layer so we can get healing of those tissues back to the cemental surface. So you can see here the before, this is B, and then this is the D. This is the after look at the root surface. So you can see that quite a bit of that smear layer, as mentioned in the study, is no longer there, and we see those dentinal tubules here. Sulfonated phenolics have the potential to partially remove the smear layer from root surfaces more efficiently than any other locally adjunctive antimicrobial agents, which will facilitate to some extent periodontal tissue reattachment at the intervention sites. So that is really exciting. You can be thinking microscopically, okay, as I place this sulfonated phenolic along this root surface, it's going to remove that smear layer, and I'm hoping that my periodontal ligaments and my junctional epithelium will be able to reattach back to those areas. Now, I do want to stipulate here that you notice those dentinal tubules are open now, right? And when we do have open dentinal tubules, sometimes that can cause sensitivity. I personally have not had any of my patients be like, wow, this was overly sensitive in these areas. You can recommend still whatever you normally have your patients use for sensitivity, maybe a fluoride varnish or potassium nitrate or whatever it might be. You can continue to recommend those things. But usually after periodontal therapy, like in my consent forms, I do always mention to patients that there will be some sensitivity and root sensitivity afterwards, especially as the tissues are shrinking and the roots are exposed. They're just naturally going to have maybe some more sensitivity. So just it's just a continued conversation of with what we are already doing, that there might be potential sensitivity after our treatment today. So smear layer removal is just the disintegration of that organic material. Reminder, as Sue mentioned, it's an acid, but it is not acidic, going back to our chemistry classes. And so I did want to show you this study that they did on comparing it between a citric acid, like an orange juice or a yogurt. And you can see that a sulfonated phenolic is a lot less mineral release than any of those other ones. So it's just normal release that we would have of any of those minerals as if we were eating, traditional foods that we're already eating. So here's another case that I wanted to show you as well. Sometimes you can customize the product. So what I mean by that is maybe everywhere else looks pretty good, but you have, an 8mm pocket or, whatever it might be. You could choose to place it anywhere that there is inflammation, or, if you're doing like a follow-up or re-eval, you can put it in one like localized area only. So you can kind of customize how much or little that you would like to use. Essentially, anywhere that I see inflammation or a pocket that a patient cannot reach on their own, especially this 8mm pocket, these are times to place a sulfonated phenolic and desiccate that biofilm. So once again, you can see isolation, dry, dry, dry. If it touches any water or saliva before it gets to the biofilm, it will dehydrate that saliva or water first. So we want the tissues and the teeth to be as dry as possible so that they can work on the areas that they need to work on. You can place it up to 6 teeth at a time. I would say not the whole tooth at a time, but like on a facial surface, 6 teeth at a time. And then suction it off first, get off all the excess, and then rinse away. Here's a heavy calculus case. So my patients, as mentioned, I'm doing a lot of hand instrumentation. And so this is a really great product that has helped me ergonomically be better with this. So you can see here the patient their calculus in the beginning, and I placed it on there. And there are a few areas I want to point out that I did not put the sulfonated phenolic up on the tooth surface. I was thinking more gingiva at this time, but I do want you to note that like if there is supragingival calculus, you can go ahead and put a little extra up on that actual piece of calculus, as well as down in the tissues that are inflamed here, and that will help soften those areas. So if it doesn't touch the area, it's not going to work. So in this case, having it up a little bit higher would help soften and be able to remove some of those areas a little bit easier. But you can see here on the far right, you can see how the tissues are super pink. That does return after that 4 hours, like Sue mentioned, and that is definitely something that I always, have in the consent form, as well as, or my periodontal therapy consent form, as well as showing my patient afterwards. And I'm saying, hey, this is pink. It's not a burn. It's just blanched. It's dehydrated tissues. We essentially reduced the edema that was happening in these areas. And that's why you're going to see that be extra white. And it's, if they smile, they're going to be able to see it. So very important that you mention that to your patient before you start, and then remind them what it looks like at the end as well. I always remind my patients, and because usually their caregiver comes up afterwards, or their loved one, and wants to like take a peek at everything afterwards, and so I have to let them know that is normal. That is supposed to be there. As Sue mentioned, it has a bitter to citrus taste. I have not had a patient yet be like, don't ever use that. That was absolutely a terrible taste. But I do always say this before. I always tell them, hey, it does not taste that great. I'm going to rinse it out as quick as possible. But these are all the amazing benefits that it has. And usually when they hear all the benefits, it outweighs the taste for just a minute. I do love that hemostasis property. Also, it cauterizes, does a little chemical cauterization of the tissue, soothing the tissue in and of itself too. So that's another great feature that it has. We still have to instrument. Obviously, this is an adjunct to what we do. We can't just place this on and call it good. You know, it doesn't just like melt away all of the calculus and the hard deposits. We still instrument, but it softens that calculus. I don't have like a Vickers hardness test by any means to show you on, you know, like how much it reduces that calculus. That's more clinician reported that it makes it easier to remove, and easier to remove stain as well. I've replaced it with irrigation. So my periodontal, I teach the Perio 1 class where I teach, and this is what the textbook says on irrigation now. It says irrigation in addition to non-surgical periodontal therapy with like maybe a chlorhexidine solution has no added benefit to non-surgical periodontal therapy than instrumentation alone. So at our school, we also stopped having our students do a post irrigation with a chlorhexidine down in the pockets because we have something now that works better. So this could be something that instead of this irrigation, you may replace something that, you know, we find that there's no benefit to something that has a lot of different and amazing benefits as it pertains to periodontal health. So here are some of the code options that you can utilize in your practice to be able to place this. There is, I do find some practices using it as a gingival irrigation. Some use it as an unspecified procedure, either in the perio category or in the preventive category. Or if you're just using it on one localized area, you might be able to use it as a 4381. That's really going to depend on what your office and how you guys interpret your codes. The great thing about it too is that you can keep it at room temperature. It doesn't need to go in the fridge by any means, and it has a 2-year shelf life. So if you are going to customize it in a few particular areas, like squirt a little bit out, and sometimes I'll put some on a little cotton tip applicator for maybe one area, it's important to do that and put it in the area pretty quickly because it will absorb the kind of water in the air as well and not work as well as you want. So, you know, keep that in mind. But very long lasting, you know, for our patients with that 2-year shelf life. So with that, what we want to do is we saw several questions coming in. We would love to go over some of those questions with you at the end here. So I'll invite Sue back on and Haley, and we'll do some Q&A.